I'm a neonatal grade trainee and a research fellow based at the University of Nottingham. Thank you so much for the opportunity for us to share some of the descriptive work looking at the variation of dexamethasone use as well as respiratory morbidity across 13 neonatal networks in England and Wales in infants born below 28 weeks of gestation. As you're aware, bronchopulmonary dysplasia (BPD) is the leading cause of morbidity in very premature babies. Nearly half of those babies with severe BPD actually go on to develop serious respiratory morbidity and late death at 2 years of age. And nearly 2/3 of those babies with severe BPD actually go on, unfortunately, to develop moderate to severe neurodevelopmental impairment as well as late death. So severe BPD is definitely associated with poorer outcome. Postnatal dexamethasone, as you're aware, has been used since the 1990s to help to facilitate extubation and to reduce the risk of BPD. However, there are some anxieties around some of the side effects of its use, such as cerebral palsy, gastrointestinal perforation, especially on high-dose early use of dexamethasone. A recent Cochrane review published in 2021 shows that the use of dexamethasone after the first 7 days of age is associated with better BPD and home oxygen requirement, without any impact on cerebral palsy or gastrointestinal perforation. So the recent NICE guideline published in 2019 suggests or provide recommendation of considering the use of dexamethasone after the first week of age in babies who are invasively ventilated for respiratory reasons, after taking into account the various risk factors of BPD in discussion with parents. And NICE did kind of make an attempt to define some of the risk factors here, but hopefully you can appreciate that they're still open to interpretation and may lead to subjectivity in helping to identify those babies that may need dexamethasone, then potentially may lead to variation in practice. And that's what we hopefully try to do in our descriptive study to kind of explore the variation in dexamethasone use and the composite outcome of severe BPD and death across 13 neonatal networks in England and Wales, and also to assess the difference in characteristic infants with severe BPD or death, depending on whether they receive dexamethasone or not receive dexamethasone. So this is a retrospective cohort study using data from the National Neonatal Research Database. Ethics has been given by the Sheffield Research Ethics Committee, and a table here refers to some of the definition, outcomes, and practices that we use in our study. Mortality here refers to death before 36 weeks of corrected gestational age. Severe BPD refers to respiratory pressure support requirement, which is your non-invasive or invasive ventilation at 36 weeks. And that's based on grade 2 or 3 BPD definition from the Jensen 29 definition. And dexamethasone here refers to 3 or more continuous days of its use. And that's hopefully to ensure that dexamethasone was used for respiratory reasons, BPD, rather than for other reasons such as airway edema. We then use data to analyze our results, and Cochrane's Q statistics was used to assess variation, with the Mann-Whitney U-test and chi-square test, just a standard test to look for differences in continuous and categorical infant characteristics, respectively. So pretty much descriptive study at this stage. Some of the results, this is our patient cohort. We started off with over 26,500 babies born below 28 weeks of gestation over an 11-year period from 2010 to 2020 across 185 neonatal units in England and Wales. Because we're interested in babies using dexamethasone after the first week of age, we included only about 23,500 babies that survived to the first 8 days of age. We excluded just under 0.5% of babies for having birth weights that scored below -4 or above 4 because it's just not possible, probably due to error in data entry. Major congenital anomalies, being discharged a non-participating unit, so that means we don't have the full neonatal care data for them, and also a missing BPD outcome. So in our study, our overall cohort is about 22,500 babies, and importantly, of which 45% of those babies actually go on to develop severe BPD or death before 36 weeks of gestation, corrected gestational age. A bit about trend, which we kind of know from previous studies and kind of correlates with what we know previously from either UK or other high-income countries. So this is the trend of the various outcome over an 11-year period from 2010 to 2020, with the death show as the rate crosses, severe BPD shows as the red triangle, and dexamethasone use shows as the blue square. As you can see, severe BPD rate has actually gone up over the 11 years from 32% to 42% on a backdrop of improving survival, with mortality dropping from 14 to 12%, with a concurrent increase of dexamethasone use going up from 13% to 21%. Then we look at the variation across the network. Here we look at the composite outcome of incidence of severe BPD and death before 36 weeks, and that's shown by the red triangle, and the dexamethasone use shown by the blue square. And these are kind of the unadjusted observed proportion of babies, with the 95% confidence interval shown as the riskiest, and the dotted line, horizontal line, shows the national average. So 45% of babies in our cohort develop severe BP or death, and 17% of babies receive dexamethasone. We then arranged the 13 network based on increasing order of incidence of severe BPD and death. So kind of a more adjusted modified caterpillar plot, I guess. And the two key things that strike out to us, I guess, when we look at this is hopefully you can appreciate there is some variation of practice across the 13 networks for both the composite severe BPD and death outcome, but also more strikingly for the use of dexamethasone, which is quite striking. The other thing to suggest in OSD is just looking at it, there was no obvious trend as to whether in regions where used above or below national average of dexamethasone is associated with better or worse respiratory outcomes. So that's quite interesting to know and kind of adds to the story that there's still lots of variation in practice. Moving on to what we are more interested in, I guess, those babies who've developed severe BPD or death before 36 weeks. As a reminder, nearly half of those patients in our cohort goes on to develop that. Just as a recap, in our oral cohort, about 89% of babies actually survive to 36 weeks. Of those babies that survive to 36 weeks, nearly 4 in 10 of those babies go on to develop severe BPD. But when you look at babies with severe BPD, only about 1 in 3 of those babies receive dexamethasone. That kind of begs the question, what about those 2 in 3 babies who did not receive dex but also developed severe BPD or death? Are they different from those 1 in 3 babies that develop dex? And also, could they have benefited from the use of dexamethasone? We then kind of compared in basic infant characteristics in babies with severe BP or death, whether they receive dex or do not receive dex. As expected, babies that receive dex are slightly more premature, smaller, more likely to be boys, longer duration of invasive ventilation, longer duration hospital stay, and more likely to require respiratory support discharge. So maybe suggesting that we are, as clinicians, we're probably quite good at picking those high-risk babies to the really severe high-risk babies who get dexamethasone potentially. But the key message, I guess, that was quite striking is that 2/3 of those babies, unfortunately, have not received dexamethasone. And out of that, about half of those babies go on to require respiratory support discharge, kind of suggesting they potentially may have benefited from the use of dexamethasone. So just to summarize, hopefully I've demonstrated that severe BPD rates has increased on the backdrop of improving survival with increasing dexamethasone use, and also demonstrated that there is some variation across the 13 neonatal networks for the composite outcome of severe BPD and death, as well as dexamethasone use. And also 2/3 of babies that receive dexamethasone, 2/3 of babies that have severe BP or death did not receive dexamethasone that may have potentially benefited from it. The major strength of study is the near complete patient coverage, so it do reflect the current clinical practice. A potential limitation is the retrospective nature, as you're aware. Association seen cannot be interpreted as causality. And also we don't have the true indication of the starting or the usage of dexamethasone in our data set, but hopefully the definition that we use of 3 or more continuous days will hopefully limit to focus the dexamethasone to just for BPD reasons rather than for other reasons such as airway edema. So there is still some anxiety around dexamethasone treatment. As you can see, there's lots of variation in practice, but also what's striking to us is about 2 in 3 babies with severe BP or death did not receive dexamethasone, of which half of them still require respiratory support discharge. So kind of suggesting that there's still some uncertainty in picking the right babies to receive dexamethasone at the right time, and may suggest a need for more objective measure to help to identify those babies early on. Thank you so much for your time. I'd like to thank all my supervisors, especially Professor Don Sharkey, and all parents, carers, and healthcare professionals participating in the UK Neonatal Collaborator. Thank you.
Okay, thank you. Questions already, Karen? Thank you very much. Excellent work. Karen Lloyd from University of Bristol. In your analysis, you kind of focused on the survivors, didn't you? I mean, I would use dexamethasone if I thought the baby was going to die. So what you're doing is you're pushing babies from so surviving, but into the category of severe BPD then. Did you look at mortality separately from chronic lung disease?
So
between the network, doing that same analysis?
In just the mortality?
Yes.
Whether there's variation in practice, mortality,
Yeah.
I've not done it, but it's a good point, something that we could potentially look at. And the reason why we focus on those survival is precisely for the reason that you suggest, that most people start dexamethasone because they are kind of pushed to the limit in terms of high-risk babies, that you want to prevent those kind of death. But I guess the other flip side of those thinking behind that is that we are not that good when it comes to borderline grey cases, such as those babies that survive. And actually, those are quite big population of our babies, about 2/3 of them. So I take your point that it's true that we, as clinicians, we normally start if they're quite bad on, and it kind of shows that those babies that had dexamethasone are slightly worse outcome. But the other flip side to the coin is 2/3 of those babies actually did not receive dex, and actually they're quite bad outcome as well. But
it would be interesting to, because you've probably saved more babies, I would suggest, but yeah.
Thanks, team. Fantastic. Yeah, Chris Gale, Imperial College London. Lovely to see the data presented in this way, and really striking the difference in the rates of postnatal steroid use across networks, and looks pretty much like it's unrelated to the rates of severe BPD in those networks. And I just wonder if receipt or not is detailed enough, because there's been a lot of suggestions that timing is very important, isn't it, as to when you give the steroids, and if you give them just very late, then actually you may have missed the boat, and actually the chronic lung disease is so well established at that point. So I wonder if you're able to kind of nuance that analysis a little bit further and look at timing across those networks and see if there's any relation. So
there's definitely potential of doing that, kind of like a subsequent analysis, looking at not just whether the use of dexamethasone, but also timing of dexamethasone. In some of our previous work that we've done using the similar data set, we've kind of shown that actually there's a time component to it. If you start dexamethasone after 4 or 5 weeks of age, it may not work. The inflammation has already been more established in that sense. So it kind of brings back to that discussion we have with Dr. Liu, that we're so good at starting early if they're kind of death stall kind of thing, that we're still missing out those big chunk of babies, and we might delay that decision and it might not work. So that is kind of the second, I guess, the part 2 of the story, where there's variation when dexamethasone started.
Yeah, we almost need something to better predict babies that go on to get severe BPD in the UK population, don't we, Tim?
Yes.
Great talk, Tink. Hi.
Hi.
Thank you, Cheryl Battersby from Imperial College London. So I guess some of the uncertainties of whether we give steroids because of fear of long-term neurodevelopment outcomes. And there's also clearly a question whether BPD is a good predictor of future lung health as well. So as an outcome, it's a bit, unless you can actually find a biomarker that really predicts your long-term lung health, it may not be the best one we're using currently. Have you got future work to look at longer term outcomes so that you can, disentangle that? Yeah,
so it's true that BPD is quite heterogeneous, and associated long-term outcome is quite, there's lots of debate around it. So in this initial first stage of work, we also plan to look at being discharged from home oxygen requirement. So that's not as long-term, still a bit short-term, but obviously that's an area that's quite significant from parents' kind of point of view. But we're also planning, we are actually kind of running a multi-center prospective study to kind of hopefully initially collect neonatal data with a further plan to collect kind of 2-year follow-up data kind of thing. So in the pipeline for future work.
Kevin Goss from Southampton. Again, really lovely work. Thank you for presenting it. I was wondering whether, given that there are a lot of factors which can influence outcome, and whether the one change in practice which I'm aware of, which might have happened during the period that you were studying towards the end of it, was the Peri-Prem project and its introduction, and some of the things in that which included the use of prophylactic hydrocortisone, like in the Premilox study. The numbers needed to treat to prevent a a diagnosis of BPD or death with something like 13, 15 babies treated to see a reduction. Could you start, it's not been taken up universally, but within the group of babies that you were looking at, presumably there may have been some babies that fell into that group. Could you start to see any differences, do you think, if you extend at the end of your study, whether there was any measurable impact, I guess, from those kinds of groups of a package of care, like the peri-prem study?
Prophylactic hydrocortisone, obviously that kind of came on our data set, as you're aware. It probably Premloxtal published in 2016-17. It kind of came in around the later half when we saw an increase kind of thing. But it's even at 2020, I think in our data set, it's only about 17 to less than 20% of babies actually receive hydrocortisone, and we define it as 7 continuous days of its use kind of thing. So I think that question may not be able to answer fully within our data set, but with more data in subsequent years, that's potentially something that we could have to look at and capture.
I think we're very interested.
But there's still some variation in practice if you just look at hydrocortisone use.
Thank you. We're running out of time, but one last quick question.
It's more a comment, really. We are all just focusing on inflammation, steroids, but as you rightly said, BPD is a multifactorial disease, like caffeine, nutrition, and all this stuff. And increasingly, as you've demonstrated, there's high dose being given to all these infants. And there's lots of animal studies showing these will impact the hippocampal development in these babies. And we are hiding ourselves, saying the baby can breathe, be alive, but we don't know what they're going to do at 8 years in the school, how they're going to perform in the academic settings.
No, completely agree.
Thank you. That's excellent. Thank you.